I'm back in plenary session, virtual edition. I'm joined by Dr. Jeanne Noble. Dr. Noble is associate professor here at UCSF. She's an emergency physician, and she has been a very astute commenter about the COVID-19 crisis. Dr. Noble, it's a pleasure to finally get to sit down and talk to you.
Thanks so much for having me. Thanks for the warm introduction.
So, I'm a big fan of your work and writing over this course of this pandemic, and I'm shocked it took us so long to actually be able to talk. But I think listeners will really enjoy this conversation. I guess first I want to talk about something that you posted recently, which was you sort of went through some UCSF statistics and you tried to separate people who were hospitalized, who happened to be hospitalized for a different reason and tested positive on the admission swab for SARS-CoV-2 versus people who actually were here because they're very sick with SARS-CoV-2. I wonder if you might talk about your analysis and what you found.
Yes, and I'm even going to back up for a second and say,
Yeah.
the reason I think this is so important is because we have been advocating to pivot from case counts as an important metric for, implementing and pulling back COVID restrictions, and arguing that hospitalization rates, which is a proxy for serious illness burden in our society, should really be what we're looking at. So then looking more closely at hospitalization rates, we have, a problem there as well, which is not super surprising that we are overcounting the number of people we have in hospitals for COVID illness and are simply there with COVID illness testing positive. So I did a chart analysis. I have, I should say, since been told that I should not be publicizing my own independent review numbers and should defer to UCSF. But what I will say is that looking at doing a spot analysis, so reviewing the charts of everyone who was hospitalized with a COVID diagnosis at a single point in time, a few times over the past week, you get the majority of patients who are hospitalized for other reasons and are incidentally testing positive for COVID. UCSF has now published a dashboard where they look at for versus with COVID. So people hospitalized for COVID, meaning that's, the primary reason they're hospitalized versus incidentally testing positive. But the UCSF criteria that they're using now, which I applaud them for doing, around 40% of patients who are hospitalized, who are counted as COVID positives and reported as hospitalized COVID patients, are there simply incidentally. So their numbers are about 60%, sort of true hospitalizations and 40% incidental.
That's really important to know. And I applaud you for getting the word out about this issue. And I thought there's some nice news coverage about it. It's important. And I think just to come to your first point, which is that, of course, it is the case that simply looking at cases is not going to be a good barometer of where we are in this moment for a few reasons. One, the Omicron spreading variant is going to spread very quickly. Two, many people won't feel that sick. Thank goodness. Many people are vaccinated. They're going to do just great. Three, you have more home test kits than you've ever had before. More people are going to test. And so, you can see huge numbers in terms of case counts that don't speak to the situation on the ground in the hospital, doesn't speak to the burden of the disease. And the worst case scenario would be policy would irrationally respond to that cases as if we're talking about cases in March 2020 when we are in January 2022. So I think that's important to separate. I wonder if we might talk a moment about, I think, the issue that unites you and I more than any other, many of these issues, but particularly, is, kids and COVID-19. And there are clearly kids with serious comorbidities who COVID-19 is a grave threat. And, I think those kids and their parents should work with their providers to craft sort of personalized protection plans for those kids and what are they going to do around vaccination, et cetera. Then there's a whole bunch of healthy kids. We can focus on maybe the kids in school between the ages of 5 and 18. Right now, vaccines are available to all these kids. These kids have been asked to wear cloth masks for most of this pandemic, and just now I saw someone tweet that Berkeley Unified School District has escalated. They want the N95 masks. I wonder if you might talk a little bit about how you think about masking kids, kids in school, the evidence, and how you think about maybe even if you want to go below, this is a place, you and I are in the Bay Area, we're going down to 2. Their daycares that mask 2-year-olds and 3-year-olds. So I wonder if you might talk about that for a second.
Yeah, I think our masking policies are really misguided, and I'm afraid with this latest variant, the lack of data behind the masking of children is even more stark. So, we have you've covered this very well, but we have a real paucity of high quality randomized controlled trials on the effects of masking, and we have zero in children. So, our adult data is poor. I mean, we have a European study showing, a negative study essentially showing that there was no difference in masking in transmission rates between those who masked and those who didn't. And then we have our Bangladesh study, which had a pretty modest benefit, I'd say, for people over the age of 50. And I think some of those results are even a bit questionable. But of course, nothing in there about vaccinated people and nothing in there about kids. So to extend this, what I would characterize as very weak data on the efficacy of masks in reducing COVID transmission to a vaccinated pediatric population is such overreach that it's really perplexing to me how broadly our society has really embraced this without drilling down to the data. And we have, if we were going to do this as a nation, I'm perplexed as to why the CDC did not fund some randomized controlled trials to really look at what's the effect of masking kids in school, vaccinated or not, controlling for those, of course, compared to schools where they don't. And it wasn't done. And without that data, and I think increasing evidence of harm, it's really disappointing. So, in the harm from masking, I think, this abundance of caution approach that we've used throughout the pandemic, well, why not just do it? Maybe made some sense before we were vaccinated, but now that we are vaccinated and we're talking about a threat of serious illness that is so attenuated, it's important to look at the downsides. And, kids don't communicate well in masks. They have trouble with lip reading if they're trying to do, if language acquisition is a thing, if they speak English as a second language. It's just, there's so many reasons. In the emergency department, I often pull down my mask when I'm communicating with older patients who may be a little bit hard of hearing, and they can't understand me with my mask on, and I pull it down for them. And I mean, this is what we're doing routinely to millions of kids throughout the country. So taking this a step further now in the face of Omicron, which looks like a less deadly threat. We have a vaccinated pediatric population, school-age population, and now to up the game and have them be required to wear tighter fitting, non-FDA approved face masks or KN95s is just, it really feels absurd.
Yes, I agree with everything you said. I agree with your points that, the existing literature is terrible. I mean, I think even pre-pandemic, people forget there are lots of studies in influenza settings, and they were always poor. When Fauci went on the original 60 Minutes and said, there isn't great data, that widespread community masking is beneficial, we don't know if it's offset by you touching your face, etc., I think he was being very honest that was what the consensus was. That was why WHO didn't recommend it. We had, in a 6-week period of time, something that I've seldom seen in medicine, which was a complete reversal from pre-pandemic guidance to the idea that, hashtag wear a mask, hashtag cloth mask, save lives, etc. Within 6 weeks, without any real studies on the topic, but largely based on, I think, rationale, some biological rationale, which is true of, every failed cancer drug, every successful drug, every failed intervention, it has some rationale. So there was that rationale, and then there was just prominent spokespeople online who pushed for it and advocated to do it. And I think even I wasn't so outspoken the first few months of it because I thought you could reasonably say, look, we just don't know. And if you don't know, it's not that big a deal. And it's better than the alternative of just sitting in your house all day, literally being locked down. Maybe we try it. But I do think when you enter into year 1 and year 2 and you've never run any randomized trials, there's no randomized trials run in this country, end of story. We are hanging our hat on Bangladesh, on Denmark, and the Guinea-Bissau, they'll report soon. We didn't run any studies. We didn't run studies in kids. We didn't run studies in adults. We didn't run studies in healthcare. We didn't run studies outside of healthcare. We didn't run any studies at all. And you're getting into year 2. You increasingly find that cloth masks didn't work, and I think that's what Bangladesh shows, that cloth masks didn't meet the primary endpoint, even in a population with no immunity at baseline and no vaccination. So that's where it's going to work, if anywhere. And now we double down on the policy in the face of a variant that clearly is going through or around cloth masks. We are double down on the policy to more intensive masking, which has never been studied like this. And then the only other point I want to make before I'll pass it back to you, because I feel like you have some things to say. The last point I want to make is, some people ask me, do you know how much language loss will be there in kids who've masked for 2 years? Do you know for sure what will happen to them? You don't know for sure, that there's a lot of uncertainty around the harms as well. And I want to say, yeah, that's true. That's because last I checked, there's no society in human history that ever did this for so long for so many. It just didn't happen. So how can anyone have generated data on the harms of something that you've never done? And even in societies where facial covering is the norm, in some settings, it's not true in all settings. It's often not true in the house. It's not true with women and young children. It's not true, among young children and their peers. So even societies where this is some degree a part of the practice, they don't inform what we're doing. So I really think it is an unprecedented intervention that's motivated, I think, in part by anxiety and plausibility, contradicted by good evidence, and really captured something and became sort of a tribal identity, and it's really sort of lost control.
Yeah, I mean, I think that is it in a nutshell. I mean, it is a tribal identity. We have a real political attachment to wearing masks. I mean, it is I don't know, it's emblematic of your democratic affiliation or that you're doing good for the community or whatever, but it is signaling, I think, much more than a true intervention. And in terms of measuring the harm, I mean, we don't, this perpetual masking, if we have a hint that it's harmful for kids, we're really evading, not following the principle of first do no harm. I mean, we shouldn't continue to impose an untested intervention upon a vulnerable, essentially voiceless population, just because we don't have abundant data and quantified harm. I mean, we need to act as we do in medicine, and we don't do interventions where we are concerned that the harm may outweigh the benefit, regardless of the real quantitative data is there. Until we have the data of safety and lack of harm, we pull back unless we're in an emergency situation. I mean, and listening to you retell your sort of approach to masks throughout this pandemic. I mean, I was the same way, or maybe even, more of an advocate early on. I mean, I made YouTube videos, which it makes me laugh now, about how to make a mask out of a face towel, out of a towel and a t-shirt. And, was really a proponent when I felt like we had almost no tools in our toolkit. We had this very scary disease, raging through our communities, and we would do everything we could, even though we didn't know how effective those particular interventions would be. And we are in a completely different universe now. And so holding on to these untested interventions that the bulk of the data would tell us they're not likely to have much of an effect, just as you pointed out with Bangladesh. If we don't see a robust effect in an unvaccinated community where the disease is prevalent, we're certainly not going to see it among a bunch of vaccinated 6-year-olds. Then it's really sort of mind-boggling. I mean, it's hard to imagine what the off-ramp will be given the paucity of data we have now.
Yeah, and I feel very similarly to the way that you put it. And I think, you make a really interesting point that early on in the pandemic, you told people how to make this cloth mask, which is true, which is that, I do think when you face an unprecedented crisis, you get some period of time. I don't know what the right number is, 3 months, 6 months, 9 months, some period of time where we're just going to have to do things. We don't know for sure. Let's just do this because we've never faced a threat like this. But at some point, year 2, year 3, you got to generate data. And if you're not going to generate data and the situation has markedly changed on the ground, you have to ask yourself, what will be the off-ramp? When will you ever stop doing it? And when will you, and I guess there's no ongoing studies to generate data, so that's off the table. But when will you stop doing it? Let me ask you about, I guess I'm very curious, and I don't know for sure, but, of all the people who I think have been very nuanced communicators on this virus, I put you in that category. But you have something that distinguishes you from all the other people who I think the world of, which is you're actually a frontline emergency medicine physician. So, I think, and I love my colleagues in the ER. I think they're such an important field. And actually, I quite loved it when I did it because, it's few things in medicine that you just don't get to, there's nothing you can read off of. You're really meeting a person and there's no prior note sometimes, nothing. And you really have to figure out what's going on. And it could be the worst thing in somebody's life or it could be nothing, no big deal. And you have to sort that out in a short period of time. It's really a great field, and it develops a certain type of thinking. That said, I think many emergency physicians, like all of us, were influenced by what we see. And I absolutely agree that you can see in a bolus of pandemic spread, a lot of people flooding the emergency room, and it is going to be frightening and scary. And you're not going to always see the denominator of, millions of people at home doing okay. You're going to see the tip of the iceberg, the worst of the worst coming into the ER. And I think it is natural and inevitable that somebody in that position will say, my God, it's too many things coming in the door. We got to lock down all of society and close all the schools and make everyone wear a 95 mask. It's natural. You are somebody who is in that space, but you've always approached those a little bit differently, because I think you've been an advocate for school opening, which actually I don't think drives viral spread that much, now that we have a lot of evidence. But, you were an early advocate for school reopening. How do you wear your clinical hat? How do you separate it from your policy hat? How do you think about those things?
Well, they do overlap in the sense that when schools were closed, the prolonged closures, when they, spilled over from the end of the 2020 academic school year to the fall of 2020, we saw a huge uptick in the number of kids coming into the ER in mental health crisis. And that was, primarily teens. And then I started looking at the numbers to that, and it was very clear that kids were not coming into the ER for COVID disease. They were coming into the ER because they were suffering from eating disorders, terrible phobias, anxiety, suicidality. And it was really, it was the anecdotes were overwhelming. And then looking at the data supported that. We saw huge increases in all of these mental health conditions among kids. So, I think that's, you're totally right about your personal perception cannot be the drive for policy, because you will never have a large enough denominator to make rational policy, but you can be tipped off by what you're seeing, and then look at the data and get a larger denominator and then really see. And that for me was really it. Seeing, basically no kids who had COVID and who were symptomatic with COVID, and lots of kids who were in terrible crisis, and then polling the numbers and saying, we've got to get schools open. I mean, we can't do this to our kids. And I think throughout the pandemic, in the United States, we have viewed children primarily as vectors of disease. We have not been viewing them as to what is best for our kids, which is really kind of sad. I mean, I think there's many societies, probably most societies in the world, really prioritize their children. They're the future. They are, we live on through our children after we're gone. I mean, we should cherish them. But for whatever reason, in the United States, our COVID policies around schools have been primarily determined by, were these little vectors going to spread disease to vulnerable adults? And the analysis really ended there. We have had, fortunately, more attention to the mental health crisis of our kids in the last, 6 months or so. But I felt like the silence was deafening during the actual school closures, that it was all about, adults being hospitalized, could kids spread to their teachers, and almost nothing about what kids were actually suffering in real time, when we could have done something to prevent that.
I think you put it so well. And I think that it is a hallmark of most cultures I'm aware of that the kids and the next generation is prioritized over older generations throughout all cultures. But this has been a strange inversion. And kids are largely powerless. I mean, no one's an advocate for them. And that's why, I think when I saw the organization that I thought should be the advocate for children, the American Academy of Pediatrics, when they dropped that mask down to 2, which blatantly contradicts the WHO and UNICEF, I thought that was a problem, because it also told me that I don't know who's left out here to fight for kids if they're not the ones to do it. And in fact, they're going to be complicit in what I think is a great error, which is recommending masking at ages it's never been done with no credible data, and doing so with the fiat of the organization and the imprimatur of the organization. But one of the things that strikes me about children is that it wasn't late in the pandemic. It was rather early in the pandemic that we had some sense of the risks to kids. And it was clarified with time, and it is clearly different with a kid who is undergoing stem cell transplant for leukemia. Of course, that kid is very vulnerable, and I would do anything possible to protect such a child, and I would advise families in a very personalized way on what they ought to be doing. And maybe in such a situation, you might want to really be precautious. It's different than a 5-year-old child who is normal weight and no medical problems. A 7-year-old child, normal weight, no medical problems. I think we know now, 5 to 12, the risks are vanishingly low if you're getting infected with SARS-CoV-2 for bad outcomes. We have data out of Germany for healthy kids 5 to 11. Hospitalizations are as low as you see. ICU visits very, very low. Deaths are virtually unheard of. I think there were 0 instances of deaths in a healthy 5 to 11-year-old in the whole country of Germany during the period. When you start talking 12 to 18, the risks are a little bit higher, but they're still super, super low. And, as a rough order of magnitude, they're often 1 order of magnitude lower than things like car accidents and suicides and things that, do afflict that population to quite some degree. When I look around San Francisco, one of the things that baffles me is, this is a city where people like to take their kids to school on a bicycle. And I see them biking with the kids, but it's busy city traffic, and that's not zero risk. In fact, that's actually, I've actually somebody who rides a bike in a city a lot, and I've been hit by cars over the years, and I would say it's you don't always want to bike on city streets. The kids on the bike are often wearing the N95 mask. Stanford has the study of how many people biking around Stanford campus, no helmet, but a mask. I guess the point I want to make is that something was wrong in communication if the parent taking the kid on the bicycle with the mask on thinks that COVID is the risk to the kid and not that the fact that the daily commute is maybe a mile, 2 miles on a bicycle. That risk is much, much greater to the kid in terms of some driver distracted looking at their phone makes a little turn and boom, and I guess the same, you could even compare it to, it became somewhat taboo to compare it to things like influenza. But the reason that comparison I think is useful is that we did not ever think that you would shut down all children's sports because of influenza, even in bad seasons, even though they actually probably are the driver of that respiratory virus more than SARS-CoV-2. And yet, so the standard around COVID-19, if you compare it to driving your kids in the car, riding with your kid on the bicycle, the risks you take year after year for 20 years before this pandemic, it just doesn't make sense. And it really was an outlier. It was irrational. And that just always stuck with me.
Yeah, I mean, we really are not approaching this in any kind of quantitative way where we weigh the harms against the benefits. And it is, I don't know, I hope that can somehow be our way forward if we publicize those data more, side by side. Here's your risk of, serious illness and death from influenza. Here it is from using a swimming pool, from riding your bike, from COVID. And really try to give people these data points that I think they can internalize. I'm not wildly optimistic because that data has been put out there, here and there. But if we could get our, say, policymakers, our public health at the county level, to start publishing data in those forms to put the risk in perspective, maybe that would help us stop this kind of reactionary policymaking that has been with us for 2 years and counting. We'll see.
What are your thoughts on the mandates, vaccine mandates? And who do you like them in? Who do you not like them in? How do you feel about them?
Yeah, so I have to say that my perspective has evolved over time. And I actually wrote an op-ed in support of vaccine mandates several months ago. And my motivation, I have to say, was that if we got kids vaccinated, I thought that was the quickest path to returning their lives to normal.
I see.
And, taking kind of a utilitarian view, which is, I know kids are really being harmed by school closures, and I am worried about this perpetual masking and, the fact that adults can't come on campus, sports, and I mean, there's just so many negative repercussions that are continuing to impact kids' lives. And I was naive, I'd say. I'm not sure why. I mean, this pandemic has been full of disappointments, but I did think months ago when I wrote about vaccine mandates, really sort of getting kids' lives back to normal, that was a clear motivation to do it. I was wrong. And so at this point, I don't think that, it's similar to requiring vaccinated people to wear masks. Mm-hmm. We have not rewarded the good behavior that we were all seeking. Mm-hmm. Primary vaccination is what's so important, and all of the attention to boosters, although, boosters I think are very helpful for people in assisted living and, right. Over the age of 65 with significant comorbidities, et cetera. But from our sort of public health messaging, you would think that boosters were as important, or, you know, almost as important as primary vaccination, which is just dead wrong. And I think that vaccinating kids and getting their lives, you know, my thought was we would never close schools again and they would not have to mask if they got vaccinated. And that would be a reasonable trade-off. And that hasn't happened. You know, some schools are closing again and nobody is taking off their masks.
Right.
So
Right.
kids took one for the team once again. And I, you know, and
yeah.
kids, sorry, go ahead.
Not just gonna say Berkeley Unified is like 95% vaccinated, and they just escalated to N95s. You know, so
Right.
it's the opposite.
So, yeah, there's really no end in sight. And I should say, you know, vaccinating children in the primary vaccine, I don't think that the COVID vaccination, you know, requiring that for schools as we do other vaccines, I don't think that it's that different. But we have gotten I'd say a little bit out of control now with this emphasis on boosters. And, you know, I've already felt a little bit hesitant about my strong advocacy for, you know, we got to get all our kids vaccinated so their lives return to normal. And that hasn't panned out. And now adding that, the boosters, when I'm actually quite concerned about booster doses in our adolescent males. And so we're again crossing that line of, you know, we really need to stick to first, do no harm. And I think with this rush to, you know, not only we vaccinated all our kids, but now we're going to boost them, I think we're really running the risk that we are going to cause more harm than good in our individual children.
Right.
And that's not right.
That's really well said. And actually, I feel very similar to you because I remember in like the peak school closure, you know, as somebody who was always kind of critical of the masking literature and just starting to look at it, we were doing what eventually became our like 30,000 word article that we published, the working paper. We were working on that, so we're starting to see the literature. But I remember thinking, I'd rather these kids go back to school with a cloth mask than not go to school at all, you know? So that was a sacrifice. I was like, you know, I'm not sure it does anything. And in fact, the more I read, I'm getting a little suspicious that this has got low credibility evidence. But better that than stay at home. And similarly, I think you felt better they get the shot, then they can take the masks off and go to soccer practice and return to normal life. That's better, even if to some degree what we're doing is we're vaccinating to lift a guideline that we may have wrongly imposed in the first place, you know? Like maybe we shouldn't have prohibited all those things in the first place. Like when kids play outside soccer, maybe they could have done that the entire pandemic and things would have been fine. In fact, that's probably the case. It's outside anyway. So, you know, I felt I've been where you are. And I also think the other point I think you're making is very astute is, you know, I wish the policymakers would talk about the importance of like a dose of vaccine. So obviously you got one vaccine. Who do you give it to? An 85-year-old. Second dose, 83-year-old. Third dose, a 70-year-old with heart failure. Fourth dose, okay, you go down and down and down and down in age. And then once you get to, I think, maybe even the 40s or 30s, and then they give you the next dose of vaccine, then you probably go back up to the beginning of the line. Give them the second dose. Give the third dose, you know? And then they give you another dose of vaccine. Okay, then you come down the line. And that's how we should have been thinking about it. Like somebody's handing you the doses. Where's the most good you get with each dose at a time? And I think if you think about it that way, it would be clear. The third dose in a 12-year-old boy, that's 5 years from now. You know, even if, you know, we have other fish to fry. We got 85 years and never got the first dose. Give them the first dose, hold off on that. And then as you get further out, I think the risk-benefit calculus is really questionable. And, you know, we've done a lot of modeling. And I think that I'm pretty persuaded that for adolescents, maybe one dose is preferable to zero. But is 2 doses preferable to 1? I really struggle. You know, I don't have a clear sense on that. And I think we haven't really had the honest conversations. And for a healthy 5-year-old, if you have proof they recovered from Delta or Omicron, I think it's a real struggle to know what is best for them. Now, of course, if the answer is if they don't get the shot, they're not allowed to go to school and they're not allowed to play and they're not allowed to go to, you know, then you're like, okay, fine, just do it. It's the risks are always, you know, very low. The potential upside is very low. The risks are very low. Let's just get this over with. But I think you're right that promise is a false promise. At least it feels that way. And when you see places like Berkeley with the highest vaccination rate escalating, I mean, it's really disappointing and depressing.
Yeah, it is. And there are several schools that are considering or have already said that they are going to require booster doses for their high school students to consider them fully vaxxed. And yeah, it's depressing.
And I guess one point there, I think, is what about the kid who really adamantly or their family does not comply? And I guess you have a choice as a school district. Do you throw this kid out or keep him in? And probably it's always the wrong policy choice to throw the kid out. I mean, I think that's just bad for the kid. It's bad for you. It's bad for society. It's detrimental. I wanted to ask you this. You must have some emergency medicine physicians who don't agree with you. Okay? But at the same time, I know people who know you personally who love you. Even those who disagree with you, they love you if they know you personally. So I guess my question is, how do you handle that from the people you know? I mean, I think it's easier because people who know me, and usually people who know me longer, they're like usually more persuaded by me because they're like, oh, he usually knows what he's talking about. Okay. But how do you handle the people in your profession who you don't know super well, not intimately, not familiarly, that you disagree with, and how has that been for you?
I think engaging people all the time with conversations in the emergency department, for instance, it's a real team environment. I mean, we're working in crisis situations all the time, which is really bonding. And so we're a close knit group, and we have a diversity of opinions across the emergency department, as you alluded to. But I think continual dialogue is really key. If people understand your motivations, and you're not maligned by your character, or considered an anti-masker or this or that really helps. So if you can push away all of the kind of distracting political tribalism, for lack of a better word, then communication, I think, is much better. And I think we have more of that in the emergency department. Emergency department is kind of a rough and tumble place, and it is clarifying from that sense. I mean, it's we're used to sort of sharing and getting down to drilling down to what really matters, and I think that helps with our COVID related conversations.
I guess that's very interesting to hear, and I guess I have a secret thought, which is that we all know what 1% of doctors think with a high degree of precision. Like, I know what you think, you know what I think, I know what Monica thinks, and I know what a few people who I disagree with think, because I see it often. But I don't know what 97% of doctors think, actually. I don't know. And I think people feel as if they know from the likes and retweets and that kind of stuff. But I don't think you really know, and I think you know very little. And the other point I want to make is that when you see the New York Times has the survey of epidemiologists, it's not a real survey. I mean, it's a survey of the epidemiologists that they reached out to, which are likely very selected in a bunch of ways. And I think maybe journalists are a little bit different than doctors in the sense that, if I were to make a guess, I would say journalism is a profession that you did not have to go anywhere to do it during the pandemic. You didn't have to, and professions, and it's also a profession where people are very highly educated, and they went to the top universities, and they are also left of center, heavily left of center. They live in certain types of cities over other types of cities, and I think it's very plausibly the case that the median journalist is much more on the spectrum of pro-mask, pro-vaccine mandate, pro-lockdown, pro-shutdown, what do they call it, circuit breaker, whatever these things they call, the idea that we'll keep locking down again, than the average person in America. Doctors, I think, are different because doctors, I think, they're doctors in red states and blue states, and they're doctors in rural places and urban places, and doctors, we've had to go in. I've been... I go in fact, I look forward to it. Actually, get there and get to the hospital and do some work. We've been going in face to face, and I'm grateful for it. Actually, I'm like, it's really nice to have a job where you really do have to go in and do it. It means something. Like, there's no computer ever going to replace me, even though they talk about there's no computer going to get you can be able to go in and do the work. So that's the doctors, and we see a very tiny fraction of doctors who are vocal about it. And we see a lot of doctors, I think, get into a dialogue with the journalism. In fact, the ones that are most frequently on the news shows, I think, are in sort of a dance with journalism, and therefore they're quite aligned. But I do think we really don't know what most doctors think. And in my field of oncology, anyways, it's a long-winded thing, but the reason I was getting to is my field of oncology, I sincerely believe that many oncologists are frustrated by the response in many ways because we are a field that has always dealt with life or death. And we're a field that always knows there are fates, there are things that people who are dying will not give up. I've had patients with bone marrow transplant, immunosuppressed, and they got a grandson's birthday party, and you're like, I don't know. It's seems like a high risk situation. They say, this is why I'm living for, to go to these things.
Yeah.
So we're always balancing living life versus sort of risks, and I think all of us, we're frustrated by like the quality of the care we can provide. So many of the services have been hindered, and I think I don't know where the midpoint is, and I think that people may agree with me quite a lot. And they're just not vocal about it. In fact, my email inbox tells me that.
I just want to echo that. I do think that, although there's a diversity of opinion, so say in the emergency department, no, this is anecdote, of course, I don't have any quantitative studies on it, but most people in the emergency department who work there, or staff members, are not afraid of COVID or contracting COVID. And the concern for it among us who have, been going to work every single day is that, oh my God, if I test positive, I'm a close contact for my kid. My kid's not going to be able to school. I don't have daycare tomorrow. It is all the practical repercussions of our COVID policies without, I don't remember when the last time is I've heard a healthcare provider in the ED vocalize fear of disease. It's fear of testing positive.
Yeah, it's fear of like how disruptive that will be, and I don't know, the dread of like I don't know, like for myself, like if that happened before I had clinic, it would be such a disaster because these kind of cancer clinics are not the kind of clinic anyone can substitute for you. Like people know you for a long time and they need you, and you make decisions different than other people, and they're gotten comfortable with it. I think it's tough. Yeah, everyone I know is worried about what it would do, the disruption that would come from a positive test, rather than the actually getting sick part, which I think I'll be okay. I've been sick before. I know what it's like. And I, drink some orange juice. I lay in bed, and I've been vaccinated, and I'll probably do okay. I wonder if you might talk a little bit about, I don't know. Do you feel Omicron is different? I feel like one thing is different to me, which is that Omicron is finally gotten. It has finally gotten a lot of people who did, quote unquote, the right thing, have been very precautious. Now they're getting infected. And so I think to some degree it's kind of bursting the bubble around COVID-19 and, the fear of being sick, et cetera. I wonder how you feel. Is it going to change things? Are we going to be in a better place in 3 months?
I think so. It's, Omicron does seem to be the great equalizer. People are, testing positive all over the place. And so it becomes a shared experience, not, less of an us versus them. And, people are building up their immunity. We have, I'm surrounded primarily by vaxxed and boosted people, including, our ED population. People are coming into the emergency department, the sick people that we see with COVID are either unvaccinated or really immunocompromised almost without exception. So we are certainly, as this spreads through, people are building up immunity, vaxxed or unvaxxed. I think the fact that we will all now know multiple people who have had Omicron has got to decrease our level of fear and the panic and the policies that follow that. But I don't know, I've been disappointed, like I said, by many paths that this pandemic has taken. I do think we're at the point where we should really be trying to make endemic focused policies, like realize this is here to stay. We really have to focus on serious disease. We've got to pull back our restrictions wherever we can. But I don't know when California is going to head in that direction, frankly.
I don't know either. But you say California, but I recently was traveling in the state, and I'll tell you something interesting. In this city, you walk outside here, you got 75% masking right there outside, on the street. You go 1 hour out, 50%. You go 2 hours out, 25%. You go 3 hours out, and I was in a Target, and I swear people were staring at me, and I wondered, did I do something? And I was the only one with the mask on. I was the only, so I think that even this state is very heterogeneous. I'm curious about staffing issues. And I wonder if you feel like how I feel. So I guess maybe I'll offer my opinion and then let you react to it. I feel to some degree it would be ideal for healthcare providers, particularly older ones, to get vaccinated. I'm not, of course, I would support them to do that. The moment you start making it a mandate and firing people for not complying, then I think it's a little bit tricky, because in some places in this country, you know, people have been taking care of sick people this whole pandemic, and they themselves have gotten sick and recovered, early in this pandemic. And vaccination is something that, we're still working with with the population on. There's some people who, are still reluctant. You start talking about firing these people. Then you end up in a situation where your hospital short-staffed. And I feel like, to me, this isn't great. And I wonder if the answer is, you don't have to fire these people. You could, and when you're really short-staffed, outcomes can be worse for everybody, because if you don't have labor in the hospital, you can have a total healthcare system collapse. And maybe it's better to have somebody who's unvaccinated but willing to wear a mask when they work, or willing to test 3 times a week, than nobody at all. So I wonder if you feel like we've been too, I don't know. I mean, it to some degree it is a virtue signal. Like, it signals that we're virtuous to fire these people who are the bad people. But is it utilitarian? Does it actually bring about the greater good? I wonder how you think about it.
Yeah, I think to the extent that a mandate immediately ups the vaccine uptake, then you could say, oh, well, that is for the greater good. I think that it is, I think we're past that point to whatever extent that it was helpful. I think our vaccines have been available now, widely available to anyone who wants them for a very, very long time. So if that stick was going to be helpful and up our vaccination rates to, prevent the next surge, I do think it's run its course. I think, with vaccine mandates, I feel like there needs to be an end game too. There was, potentially a reason to say we need everybody vaccinated as quickly as possible now, and you're not going to be able to come to work if you don't get vaccinated. That is a perpetual policy. I don't think makes sense. And now we do have a big staffing shortage problem. I mean, it's we have, so in emergency departments, there is a chronic, longstanding issue with having enough beds. And that's, it's complex. It has to do with our for-profit healthcare system. But, whenever hospitals need to make, more money, more surgeries happen, and there's no more beds to admit sick patients out of the emergency department. So the admitted patients stay in the emergency department, and our real estate, so to speak, for new incoming patients diminishes and gets smaller and smaller. And then that is compounded by the fact that we have often not enough nurses to staff the beds that we have. With COVID, and particularly with Omicron, we've had, pretty aggressive occupational health policies that say, if you've had a high risk contact, you have to test even if you're asymptomatic and wait a period of time. Or if you have new symptoms that could possibly be COVID, such as a stuffy nose or a scratchy throat, you can't even test in the first 48 hours of those symptoms to sort of define the trajectory of your symptoms. And only after 48 hours can you take a rapid test to clear to come to work. And sort of a big set of complex regulations that are keeping people who are healthy from coming in and providing care when we have staffing shortages. So there are a lot of COVID policies, I think, that are worsening the quality of our medical care, and are very questionable as to what that benefit is, which is, presumably reducing nosocomial infection, or that providers, reducing the likelihood that the provider is going to give COVID to their patient. And again, like masks, we have a real paucity of data. Like, how often is that going to happen when the provider is wearing an N95?
Right.
I mean, it seems like it's going to be pretty darn rare, but it's not at all, it's not an infrequent occurrence to have sick patients leave the emergency department without care because they've waited for 6 hours and they just can't wait any longer. I mean, that happens on a daily basis in emergency departments everywhere. And so it is a true ongoing harm. And the onus should really be to say, hey, these really strict COVID policies that keep people from coming into work when they have a very remote chance of COVID, are they really, do they pass muster? Is there the bang for the buck? Or are we reducing this big threat of nosocomial spread for providers that are wearing N95s? And we just don't have the data to say that would be the case.
Yeah, that's a really great way to look at it, which is that the more draconian the policy, the more likely that person is to leave and go home without getting care. And there's a health decrement to that. And the other thing that's interesting to me is, you're right, they're only doing it because they think there'll be no nosocomial spread. But we do know, actually, even without N95s, nosocomial spread was always very low. After the initial wave, when people figured out, we'll just need to ventilate the rooms a little bit differently. We need to wear surgical masks when you're seeing a patient, or wear N95 when you're going into the room with a known exposure. Nosocomial infection has plummeted. And so it doesn't make sense to me that these policies would be worth it. I wonder, right now, do we have less hospital capacity than we did in March 2020? Throughout this whole pandemic, our hospital capacity is whittled down, actually. We're probably, and I've seen some national statistics, but I wonder if you'll comment on it, like that we are less prepared to handle an influx of hospitalized patients today than we were when we started, which really is a bad, for all the things we did, we went backwards on that.
Yeah, I mean, we definitely have a national crisis in this. And it's hard to say what exactly the solution would be, aside from, you could have strike forces, you can have, and Biden mentioned this, I think, in his last revision of COVID policies, or his announcement of new COVID policies for 2022, to, support hospitals that are in need when you have a big surge somewhere, and, have whatever, a
deployment
United
team.
States, a deployment team. And I think that if we could do that and have targeted support, and then really pull back on all of these other restrictions that are impeding quality care and keeping providers away from, nurses and physicians away from patients, the sum benefit, I'm sure, would be high, that we would come out ahead if we did this. But instead, there's so many negative sequelae for our COVID policies. I mean, we have something like, an estimate, this is not an exact number, but I think about a fifth of our nurses are traveling nurses. So we fill our shortages by recruiting nurses from other parts of the country, and they come in. But when someplace else surges, the place that's surging offers more money often, and traveling nurses get pulled there. And so you have this perpetual state of crisis and shortages of nurses to take care of patients. And it's just, there's got to be a solution. I mean, there really would be many ways to solve this. And it's, I think we need some kind of state national policy to really help us out, because the COVID policies themselves are causing problems regardless of surges. And it really shouldn't be that way.
That's really interesting. That's a great point. The last thing I wanted to ask you about, but I also want to talk about what we didn't talk about that you want to talk about. So maybe I'll give you a second to think about that. Okay. But what I wanted to ask you about was the colleges. They are the strictest. They make your ER rules look lax. What they're doing to these double vaxxed and boosted 20-year-olds. Thoughts on this, colleges and what they're doing?
Yeah, it's really crazy. I don't know. It's interesting to look now in 2022. It seems like we've come to a place where most people have recognized it was really harmful to close our K through 12 schools. And so we've got to keep them open at all costs. And, and it's sort of whack-a-mole, like, no, don't close. And we're trying to, support and provide reassurance and guidance and the risk mitigations that people want. But I do think the underlying presumption is shared, hopefully, by, all of our national and local political leaders, is that we've got to keep kids in school, that's really important. And I think college kids, young adults, have been left out of that equation. Mm-hmm. And so now you see it's sort of running amok with, colleges going remote with their, triple vax students, and some of them having the kids the young adults go to their dorms and live in congregate settings, but they just can't go to class, which is, absurd for some obvious reasons. but I don't, nobody really there doesn't seem to be a consensus advocating for, these school leaders, chancellors to say, hey, you can't do this. You can't do this. They paid for their education. These are formative years of their lives. Yes, they're not kindergartners learning to read and write, but I mean, many of us look back at our college years as some of the most important and influential years of our lives. I mean, it's a big deal, and it's short, 4 years, and we're already starting our third year of this. So I think that we do need somehow to put the spotlight on what universities are doing and really call them out for it. With that risk benefit, the cost benefit equation, what are they trying to do? Are they trying to stop asymptomatic spread in their dorms for people who are not at risk, and then weigh that, what's the benefit of lowering asymptomatic spread versus the cost of depriving the students of in-person education? And if it's not that, if they're saying, well, we're doing this because we don't want the college student to go home and infect grandma, it's like you're starting to promote a policy that's going to have very little chance of achieving its goal. So I think the first step would be making them articulate, why are you doing this? What is your metric? What is your outcome? And then let's talk about the harms that policy is causing, and just do a calculation, put it in numerical terms. And I think that they haven't done that at all.
Yes, and that's well put. And I'm shocked that more people don't see that so as clearly as you articulated, because if you're going to say that, well, we're worried that they'll go back and spread it to their parents are currently in a city where you can go to indoor dining, no mask. There's mass, they're going to football games and basketball games and concerts, and nobody's doing anything. But you're worried the college kid's going to spread it. Okay, all right. So you just have to articulate. It doesn't make much sense to me. Everything you say, I find like I agree 100% with everything you've articulated, and I'm puzzled why more people don't see the wisdom of what you're saying, and that's what really I just never can wrap my head around. Early on in the pandemic, we learned there's a log gradient of risk as you get older. So, I think an 80-year-old's risk is between 1,000 and 10,000 times as great as an 8-year-old's risk in terms of death of this virus. Like, that's the log gradient of risk. But if you think about the excess harm of the restrictions, it's like the opposite log gradient. It's like the youngest kids, they were screwed over the most. College kids were screwed over a lot. And then, the policy was, fair for older people. Because although we didn't do a great job of protecting nursing homes either, so maybe we also screwed up. Maybe everyone got screwed over. But I really feel bad for the young kids. I feel bad for the mother who's an essential worker who dropped the baby off at daycare, and then the daycare worker wears the mask for 10 hours a day with the baby to protect the baby, and then the baby doesn't get to see a face for hours. And then I feel bad for the 2-year-old who has to wear the mask all day, except for when they take the nap in the room, where they all take the mask off and then they nap in the same room next to each other for 2 hours. With the virus naps too. The virus went to nap 5 minutes before they went to nap, so don't worry about that. I feel bad for the kid in school trying to make themselves heard in elementary school, and especially if it is later revealed that it didn't do anything to slow the spread. I think that kid would probably be a little frustrated. And I think we do see some evidence. There's a nice study out of Spain that looked at, the risk of spread by age, and they started masking at 6, and you see there's no change in the slope of that curve. It's like a smooth line. So it's sort of a regression discontinuity design, shows no effect. I guess the last thing I was curious about was, like, is there anything we didn't talk about that you'd like to talk about? I mean, we covered the topics that I think that I followed you for, and I think you're really good on, policies around kids, school, masking, mandates, which I think you have a really nuanced and good point of view on, colleges, staffing shortages, what's going on in the emergency room. What did we miss that we want to talk about?
I think that pretty much covers it. Those are certainly the top issues that I think are worth emphasizing and fighting for. And, maybe we will get back together for another podcast and celebrate that this is all over in, should we say May?
I'm hopeful that it at some point you'll saturate everyone. But here, I do have a question for you. Pre-pandemic, what was your passion in medicine? And post-pandemic, what will you be working on?
Oh God, that's so great. Global health, actually.
Ah,
So I do, before I had a gap between graduate school and then coming back to medical school, and lived and worked in Peru for a few years, working on women's health issues and access to contraception and family planning. And then went to medical school and became an emergency physician, really thinking like, what would be the best, how could I secure the training that would allow me to be most useful overseas? So I do global health work in Latin America. I've recently started some support for schools for street kids in Nairobi and in Kenya. I teach ultrasound abroad, and for emergency diagnosis in places where they don't have other access to imaging. So I'd like to get back to some of those things. They're really fortifying from a professional and personal standpoint, and like really look forward to getting out of this perpetual state of panic about COVID.
no, that's so well said. And that also gives me a little bit more insight into the perspective you bring here. And I guess we didn't talk about it that much, but when many of our COVID policies, what they did in this country was bad. What they did globally is decimating. I mean, we'll see out of control tuberculosis and malaria and poverty and starvation and worsening wealth inequality, et cetera. And all these things are going to be, the need is going to be through the roof. I also think it's going to be destabilizing. I mean, everyone says, well, it's the pandemic that did it. Well, some of it was the pandemic, and some of it was what you did to yourself in the face of the pandemic was a self-inflicted wound. But the combination will be very destabilizing in parts of this country, but also in globally. I really do worry places like India that I'm very familiar with. But yes, so they'll need you back there, and they'll need a lot more than they'll need a lot. We'll need to do a lot to think about those challenges.
Yeah, for sure.
Jeanne Noble, thanks so much for doing this. It's a real pleasure. I'm glad I'm able to connect.
Yeah, thanks so much. Appreciate it.